I really do appreciate the opportunity to be here. And as Zeke just mentioned, I exhibited wonderful leadership, I designated my travel arrangements, and I exhibited poor management. I didn't look at it close enough, and my flight is at 6 coming out of Reagan, so I apologize. I'll probably pop off the off the deck here a little bit early. And I do sincerely appreciate the opportunity to be here this afternoon. It was a pleasure for us as an organization to develop up a gradually progressing relationship with American College of Radiology, and the opportunity to provide that article that was mentioned. For us, leadership is critically important. Our organization is about 40 years old, and I've been in this role for about 4 years as we're transforming the organization. I come out of about 25 years of trauma surgery and critical care at a variety of the top-tier institutions. I'm one of those obnoxious trauma surgeons that used to evoke the trauma, bell. Hey, this case is dying, so we need your radiology services right now. Clean the deck. We want your space. And that all worked really well in the 80s and 90s, but as everything has evolved, we all, I think, have a better appreciation of the criticality of the radiology services and the diversity of those services, but also their importance in the supply chain of healthcare overall. As I left clinical care about a decade or so ago, I had found myself thinking more and more about systems of care and how to improve the overall systems and their efficiencies, etc. Wound up spending some time at the Joint Commission as their first Chief Patient Safety Officer, did a bunch of international work, and then also spent some time with the National Quality Forum and looking after their measurement strategies around safety. And it further consolidated my views on the complexities of healthcare, but it also consolidated my views on the importance of physicians being in leadership roles as we try to continue improving healthcare overall. The organization that I'm with is exhibiting its own need for transformation. I know ACR is under a period of transformation, and that's just the nature of the beast overall. This organization is focused primarily on education, but we also offer a robust career services component as well. And our view in all of this is that at some level, and society certainly still expects it, all physicians are leaders. We have the privilege of being in this profession that is still viewed highly by society. We are still the most trusted profession, and therefore we have some responsibility to continue transforming healthcare. From our platform, it's all about how do we create change in healthcare through the physician leadership advantages that are there. I'm not going to take you through all of those, but we have about 250,000 docs in our database. You don't have to be a member to take part in our stuff. We have members in 47 different countries. We have, as you can see, roughly about 25,000 have taken our introductory courses. Another 2,500 of our group have obtained the Certified Physician Executive. That's basically a board equivalent for leadership and management education skills and expertise. And then we've got a number of folks who have master's degree programs as well. We partner with 5 different universities and offer master's degrees. And in all of this, really try to make sure that we've got offerings from student days all of the way throughout to what folks are doing later in life. And we do a lot of this around careers as well. But as we do this, we also consider that if we're going to create change in healthcare, then we really need to have attention focused on these 9 essential elements. And most all of them are really motherhood and apple pie kind of stuff, right? Nothing amazing in there. But what it does underscore is the complexity of healthcare. We can all talk about patient-centered care. We can all talk about quality, safety, and efficiency. We can talk about measures and outcomes and value, but it's really difficult to make it all come together. Fortunately for us, 90–95% of the care in this country is still directly driven by or supervised by physicians. And so it makes sense for physicians to be in these leadership roles in order to help create the ongoing change. There's not a huge amount of data out there, but there is some, and then that is that when you have physicians in the CEO roles of enterprises, the quality metrics in those places will improve 25 to 33%. When you look at all of the ACOs that are out there, and now we have 3 years of data, the successful ACOs that are meeting their standards and getting their bonuses, the vast majority of them are all physician-led. Okay? You can quibble with us about the U.S. News and World Report and all the other ranking systems. The U.S. News and World Report, as one example, has its honor roll every year, 18, 19, 20 plus hospitals. The top 5 are always physician-led. Top 10, usually 8 of the 10 are physician-led, and the majority of them are physician-led. There's something about physician leadership and running enterprises that makes a difference. Now, as I said, though, you don't have to be in formal titled roles to create change, because at some level, all of us are physician leaders, and therefore, it's important that we figure the ways that we can create and influence the change as best as we can. Well, this is all about complexity in itself, right? And for those of you that take attention on innovation, this is sort of some disruption curves. And where we're at here is on the left is that volume phase that we're coming out of. This value phase that's being imposed for a lot of relevant reasons is what we're trying to transition through. And eventually, as we move through it, we'll get into higher value systems overall. On the y-axis, we're going from the fee-for-service up to global payments in different sorts of ways. And on the x-axis, we're going from encounters, obviously, to some type of equation around lifetime or overall episodes of care. And I've left those vague because we don't quite yet know what they're going to become. The value equation is very simple. Usually, it's quality over cost. I've added access and efficiency, but it still boils down to quality over cost overall. And there's a lot of attention being paid on this in the insurer and the payment world. We just had our annual meeting a couple weeks ago in DC. We had Patrick Conway, who's heading up the CMS initiatives around this, and it's a real shotgun approach in terms of the different payment models that they're experimenting with, but the underlying principle is value. It's not going away, and the agenda on value keeps getting pushed forward. So we've got the delivery systems really busily trying to handle this problem, and yet they're only working off of that 1 or 2% margin. So their attention span is distracted in how to run business efficiencies. And one of the most complex issues for all of these delivery systems is physician engagement, physician integration, and how do you try on new models of care by engaging the physicians through that process. And we're hamstrung because the education system doesn't provide us as physicians with the skill sets to really embrace these management and leadership discussions overall. So we really need to get ourselves to a point where we can better talk about management, talk about leadership, and yet we are brought up differently. When you look at the left side there, you know, we're really all about prescribing. We want intermediate and short-term focused results. We really are episodic and procedurally oriented. We love well-defined problems. And we basically work as individuals or small groups, but at the bottom there, we expect to carry all that responsibility. We love that stuff. We love the respect that we get, and we certainly embrace the thanks that we get from everybody. But leadership is a whole bunch of other things. It's a lot of diversity. It's all about longer-term results, complex processes over time, larger groups, too many darned experts in the room, and a lot of variety in their responsibilities. So it's difficult. We use some psychometric testing in some of the work that we do. This DISC tool is one of them. We've got almost 4,000 docs in the database, and as you can see, the D is all about your dominance characteristics, the I is about your influence characteristics, and the conscientiousness and the steadiness. Well, I bring this up because we love dominance. We love dominance. And we love to be conscientious about it. And we're surprisingly less concerned about influence and steadiness. So I've coined up that term that we are, by our nature, by how we're trained, by how it's reinforced, we're a bunch of conscientious dominators. That's our core traits. But that's difficult because we have to move through how do we change if we're going to create this change. Let's recognize who and what we are by and large. And as we embrace all of this, we have to recognize that the perception of your value as an individual in the field as you try to create change is only partially related to your primary expertise and your original skill set. As you shift into management roles and as you shift into leadership roles, the expectation is that you're able to acquire more of those skills. Yeah, you're always a radiologist, you're always an internist, you're always a surgeon, but you can't just walk in the room and say, I'm a surgeon and therefore I know everything. It takes a long period of time to lose these traits, but you don't lose them entirely. As I said, I'm a trauma surgeon. I'm a decade since I've been clinical. I am still trying to shed the trauma skin. It's tough, but you try to focus in on some of these other traits and recognize that this is an important piece. So from my perspective, for radiology, let me give you one example about this. I remember when I was trying to create a new ICU system in a prestigious Northeastern hospital, and I had my first real meeting with the C-suite and the executive group and gave this impassioned clinical plea why we needed better ICU services. And one of the first and early questions was, so what's the ROI on this, Peter? I'm thinking, well, I guess they think it's a different language, but why are they asking me about renal output intervals? Took me a moment. I was obviously a dumb young kid, right? So, but it was an eye-opening for me. Is they speak differently, they have different contexts, and if we're going to be able to create this change, we need to not give our primary core skills, but we have to learn some other skills, and that's what this is all about. So for radiology, I think you guys are beautifully placed in so many ways because you're in the middle of a very important supply chain. You've got this high-cost item, high-cost services that significantly impact patient care, and you have to figure out how to drive a closer relationship to the clinicians, drive an increased relationship to the patients you provide, and how do you create more change from the administrative side at the same time. And that means you need to get out there and really be working closely in developing those relationships, figuring out how best to develop them. And that's different than what we normally have done for all of ourselves. Each clinical discipline we know acts differently. We do surgical stuff, we do radiology stuff, but we have to create a new persona for ourselves overall. You guys have tons of data, tons of data. You've got clinical information, you've got utilization information, you've got financial information, and properly packaged, you can drive those relationships that I just managed to the other clinicians, to the patients, and back into the administrative groups. And that eventually will help to drive the value equation that I mentioned. How do we drive better quality? How do we drive better cost? And how do we drive better efficiencies overall? Excuse me. So it's really, for me, I think, critical that you folks, as a discipline, come out of the proverbial shadows because of the critical, important place you have in the supply chain, and to learn how to build these relationships better because it will impact how we move along into the value equation. How do we solve it? How do we make it a better place to be? And as leaders, how do we really create that change in healthcare? And in my last slide, this is much bigger than all of us. There's a lot of activity going on around multi-professional case-based patient care. There's lots of activity going on around out there about interprofessional education. And we're part of this other initiative, as it says, about integrated leadership, and there's momentum building there. So again, with the critically important place radiology has in the supply chain of delivery of care overall, I think it's important that you guys get involved because it's all coming through and it's bigger than all of us at this stage. So thank you so much for the opportunity. Stand up here. So, listen to the surgeon, listen to the radiologist, as always.
So being respectful of Dr. Angood's time. So we will take some questions. As he mentioned, he does have to get to the airport. And while people ponder their questions, I'll start with one. So, Dr. Angood, in your column, you talk about how to get started. Like how to get started in sort of an executive role. And the example you used was sort of starting with a committee or something that interests you. I wonder if you could expand on that point.
Sure. No, thank you very much. One of the other slides I talk about is if you start to have this itch around wanting to get engaged and create change, you have to recognize that the itch is there and it's not going to go away. So figure out early if it's something that is true for you. So get involved with some type of a committee in your group, in your delivery system, in your community, if you will, and figure out if engaging at those types of activities is meaningful for you. If it is, if you find that you get joy by getting involved, then it's incumbent, I believe, that you should then seek out a few skills. You don't have to get an MBA. You don't have to get this certified physician executive, but get a few other skills to gradually keep building your skill set, keep testing your skill set, and bring some goods to the discussion. And the more that you do that, you will be very favorably received by any institution that you're in. Yes, there's always politics and always priority setting, et cetera, but the well-versed, well-prepared individual who engages in a nice, politically balanced, collaborative way will get more and more opportunity. But test it for yourself first. And if that's your interest, then keep moving up in different ways. Professional societies are a great place to consolidate some of that stuff. You're in amongst all your peers, so you're already talking your own language, and just keep growing it along.
Other questions? Yes, Mark. Mark's at the microphone. I'll ask that you come to the microphone, sir, if this is being recorded, so thank you. Mark.
Dr. Angood, I'll start by giving you a plug. So about 3 years ago, someone encouraged me to join ACPE, which has now changed to AAPL, and went to one of your live courses and then started doing your online modules, and now halfway through your affiliated masters at Carnegie Mellon. And I just want to say that I think where your organization's spot on is that one of the greatest values is working together with people from all different specialties, which we don't tend to do a lot.
Right.
And I mean, one of the greatest things that besides all the knowledge that I've gained, but also to all the relationships that I've built with people from all over the country that are in all different specialties. And I constantly find myself emailing or calling those people because we all experience different things, but yet we always look at it in a different way. And so I think it's a great organization and would encourage anybody to get involved that's interested.
So I did not pay him? I did not coerce him?
I did.
How about you did? No, we are very multidisciplinary, and the groups come from all different backgrounds, different leadership types of roles, non-leadership roles, different institutions, different sizes. And what you just expressed at the end is that cohesive networking that's the most valuable for most people. But thank you so much for saying that. Sir.
I was looking at the slide you had on the 9 essential elements of patient-centered care.
Yes.
Patients were not mentioned. Where do you see the role of patients in having patient-centered care?
Yeah, and thank you for bringing that up. And we don't have it as part of the bullets because the overall purpose is patient-centered care. And the other piece that I did not mention is for us, I'd make that comment that most of the patient care is delivered or supervised by physicians, but therefore for us that physician-patient, patient-physician relationship is probably the most critical piece. And as we continue to build our educational strategies, we keep trying to bring that importance of that relationship in, as well as looking for ways to bring up not just paying lip service to patient-centered care, because we spend a lot of time on that, but the patients really are at the center of all of this. Equally important, though, is that physician-patient relationship, because we drive so much of the care. In fact, we just had our annual meeting, as I mentioned, and one of the panels that we did was all about how do we redefine the patient-physician relationship. And my challenge to the group was, what's 2030 look like, and how do we get there? Thank you.
Hi, my name is Yoshimi Ando. I'm at the University of Utah, and I had an opportunity to serve as Associate Chief Medical Quality Officer. So I'm working with a multidisciplinary physician, surgery, medicine, orthopedics, and all of those other specialties. And kind of looking at the radiology from outside of your health system view, which is really striking. And I think we all talk about physician engagement is essential element of healthcare transformations. But at the same time, the physicians are incredibly stressed, and it's an overwhelming amount of work. And And getting a physician to do value improvement work is not so easy, even though they have a good mind and then they understand the value of doing it. So do you have any suggestions as to how to get that physician to be on board, even though there's no incentive, not necessarily monetary, but it's like a technical, concrete, sort of like a value or recognition that they're doing some sort of quality improvement work. So I'd like to appreciate your comment.
Yeah, no, it's a great comment, and the way you described it is a very, very common problem, and that is the expectations that the docs still generate their RVUs, they still do a full-time load, oh, and by the way, come and do this committee work as well. There is this trend for more employment of physicians. I'm not sure that'll be a long-term lasting trend, but it's certainly going on. And that represents one opportunity to negotiate the agreements or the contracts in those employed settings. If you want me to do that type of administrative work, then I, or we, or whoever the group is, need dedicated compensated time in order to be able to more effectively do it. When you go into the American College of Healthcare Executives meetings, that's where most all of the non-clinical administrators hang out. They've got more than enough on there as to physician engagement. And it's not because they have the solutions, they're all talking about the problem it is. and we haven't solved it, but as we try to engage, be thinking ahead that there needs to be dedicated time as a minimum, and therefore an offset for clinical expectations, and ideally some type of compensation strategy to accommodate for that time. Because otherwise you're getting in there, frustrated, will not engage fully, and eventually wind up backing out or burning out or getting grumpy. And that doesn't serve anybody's benefit.
Is there any way to tie into some sort of promotion criteria or some sort of recognition as not just doing a research, clinical, teaching, but there may be some sort of a value improvement initiative to be a part of, like a full chair, one of the leg in an arm or something?
Yeah, no, I think we need more and more of that, and we don't have the time, and the other element of what we do is all focused in around career support, career services, and how do we help docs manage their careers, recognizing there's all this complexity of how to do it. And the reality is docs are very poor at managing their careers. We see it all the time. And so we've got everything from psychometric testing all the way up to coaching, et cetera, but I won't get into all of that. But docs need a place to go to figure out how to best manage their career, and that doesn't mean getting job A to job B. It's those kind of situations you just described. How do I manage my environment better? How do I draw on the local resources, et cetera? Thank you so much. I'm going to sit here for a little bit because Steve always gives a great talk, and then I'll bug out.
So outstanding. So now it's a real honor for me to introduce. Now, I briefly provided his bio earlier, but just to restate what an honor it is to welcome Stephen Weinberger to the podium to talk about crossing the radiologist internist chasm. I'm really looking forward to these comments. Thank you. I like this rhythm, so we're going to take questions for Dr. Weinberger immediately after his talk, and there'll still be time for questions at the very end.
Great. Thank you very much, Zeke, for inviting me to speak here. And I will actually make a couple of comments about leadership just to follow up on Peter's comments. One of them is that one of the pleasures of my position has been getting to know the leaders of other organizations. And I see I think Bill Thorworth left, but it's been a great pleasure getting to know him as a terrific leader of this organization. But as a transition, perhaps, into going into what I will be talking about, I do want to say that in order to be effective in a leadership position in an institution, particularly for a sort of non-direct patient care specialty such as radiology, I think it is absolutely critical to develop the right relationships with the clinicians with whom you work. And I think that will put more of a perspective of the value of the kinds of things that I will be talking about. To get the respect of those clinicians. And some of that respect comes from the ability to be working closely with them and communicating with them. But in addition, the recognition of your clinical expertise as an excellent radiologist, I think is particularly important. So let's see, I think the clicker is here. Disclosure of interests, no financial things of concern. I am a full-time employee of the American College of Physicians, and I do serve on a couple of boards which really are not particularly related to what I'll be talking about. So I want to give you a little bit of background that is based on my own personal experience. And I'm going to shed the hat as the CEO of the American College of Physicians and talk about myself as a pulmonary and critical care physician, which I was involved in for many years and actually still do see patients and teach. But as a pulmonary and critical care physician, I would say that one of the things that I often enjoyed most was the opportunity to interact with the radiologists, the pathologists, and the surgeons who took care of the patients along with me and along with my colleagues in pulmonary medicine. And certainly what I ended up learning and what ended up being most important, I think, for improving my own clinical skills ended up being that interaction, that interdisciplinary interaction with those other people. And I would say radiology was certainly right up there at the top. Now, that was in an academic environment, and there were many opportunities to do that. We had a lot of clinical case conferences and the opportunity to be able to share information about cases, to be able to provide teaching points in both directions was incredibly important. Also, those were the days before PACS systems came into play and before I could actually get images wherever I wanted, whenever I wanted, and have to go down to the X-ray file room. And certainly as a pulmonary physician, we value very much looking at X-rays ourselves and going over them with the radiologist. And as we would see patients, we would go down to the file room, we would pull the films, get the nearest radiologist or someone that we've been accustomed to working with, and go over the issues and get the teaching with that. In the teaching session also, or teaching setting with residents, we would have daily X-ray rounds where there was an opportunity to share information in both directions. Those were the good old days. What has happened since then? Well, a couple of things have happened for the better. Some things have happened for the worse, and I'll go through those. And then I'll go through the current situation, what radiologists I think need to do, and what referring clinicians need to do. So what has happened for the better? Well, obviously the fact that we now as clinicians have rapid access to the reports that you generate, that's really, I think, quite good. We can get them quickly, we can get them from anywhere, and all we need is access to a computer. At the same time, we can access the films themselves, which I think is particularly valuable. What's happened for the worse, though? Well, as was mentioned, the time and productivity pressure has been quite significant. It's as significant for radiologists as it is for clinicians. In the academic environment, the additional factor that has come up is resident duty hours, so that the residents have to get out of the hospital at a certain time. This is particularly true in the clinical setting, let's say for internal medicine residents, so that those kinds of discretionary educational things, particularly conferences that are interdisciplinary, have unfortunately fallen by the wayside in many circumstances. And the increase in human-computer interactions means that there has been less need for human-human interactions. And that is sad not only in terms of its value for patient care, but I think it's sad in terms of the personal gratification we get from the work that we do. So what are some of the opportunities for radiologists here? I think it is absolutely critical for both radiologists and for the clinicians to be trying to reach out to their counterparts. And I recognize that as radiologists, you're dealing with many, many clinicians who are referring patients. But my suspicion is that there are often small groups of clinicians with whom you work who have a particular critical mass or a particular interest in interacting with you. And ideally, I think it's important to be reaching out to show the clinicians your readiness in being involved in a variety of ways. And it's also good as part of that to set up the expectations. How would they like to interact with you? How can they get the best benefit from working with you? I do think that there needs to be selective active communication to referring physicians. And this can be done through email or through phone. And a few things that are particularly important, I think. One is, obviously, when there are interesting and important findings on patient studies, to reach out, not just through the report, but actually through personal contact when possible, to be able to discuss some of the findings on the patient studies, and if it's possible at all, to actually go over them so that the clinician can see specifically what the abnormalities and what the issues are. Also, if there are times when you are uncertain about specifically what is needed and what would be the best study for the patient because you don't have sufficient clinical information, it's important to be able to generate and to discuss those pre-study questions with the clinician. It's important to stress your availability as an imaging consultant. You're obviously not just reading films, you are a very important consultant. And sometimes we as clinicians forget that, and I think that needs to be reinforced to us. It's important to be looking for teaching opportunities. That can come through providing relevant articles or other references, particularly when there are interesting or unusual findings that you want to point out. Certainly getting involved as much as possible with either clinical or teaching conferences, case-based conferences, I think is valuable on both sides. I think that the clinicians also need to keep their end of the bargain as well. They need to be actively engaging in meaningful pre-imaging discussion. And certainly one of the things that I've seen and would often stress to residents who would write requisitions that had essentially no information on there, that it is absolutely critical for clinicians to be providing meaningful history on requisitions. And in fact, to be actively engaging the radiologists in pre-imaging discussions as far as what is the best study and what kinds of things need to be addressed. I think it's important for clinicians to request personal review of interesting and important findings, and for them to be involved in developing and participating in interdisciplinary conferences. And case conferences are really incredibly important, not only for patient care, but for our own professional development. And then finally, for clinicians to be trying, on their part, to be developing significant relationships with radiologists, establishing the expectations of what they would like to get from the radiologist, and figuring out what is the best method of contact. A few miscellaneous suggestions I thought I would put up. One, and I think this is partly a responsibility of organizations such as ACR, but it's also very much a responsibility of organizations such as the American College of Physicians that I'm with, to make clinicians aware of the radiology clinical decision support tools. And I have to say, the ACR appropriateness criteria I know have been out for a number of years, and quite frankly, I was not aware of them for a long period of time. And I would say that the internists in general are really not aware of them. So we have to work together to make the clinicians aware of those things. A point I wanted to make about role in patient communication, and I'd be interested to hear Alan's comments if he will be addressing this sort of thing. I think it's obviously important for us to be doing what is truly patient-centered care. And I think it is generally fine for radiologists to communicate preliminary normal results to patients. It often gets to be tricky when there are abnormal results, and if the patient is asking for those, how should those be communicated? And ideally, in the best of all possible worlds, if there were time for the radiologist to speak with the clinician who ordered the study and a decision can be made, bringing the patient in at that point. Often that is not possible. I think when there are abnormal results, ideally they should probably be best conveyed by the clinician, or at least to have that three-way interaction. And then finally, something I would say that internists are often concerned about are those readings from radiologists that sometimes convey a defensive posture and shift responsibility, the cannot rule out, when in fact, as a radiologist, you really do think that a certain diagnosis is there or a certain finding is there, but just to sort of cover yourself, to put the cannot rule out. And that ends up shifting the responsibility to the clinician who feels that he or she has to do something that may not necessarily be indicated. And then the suggesting additional studies, which comes as a corollary to that. So I think, being willing to commit yourself, and when there are those concerns, in fact, to convey them verbally to the clinician, I think it's important, as opposed to automatically putting it on the formal reading. So I'll stop there, and I don't know, do you take questions now or wait?
Yeah, so we'll take questions now, and I'll start with one just to initiate the discussion, and others feel free to come to the stage. So Dr. Weinberger, one point you made in your comment or your column was regarding developing sort of authentic relationships, and we all see it on our reading room. If a physician walks in to discuss a study and it's someone that we've known for a long time, or maybe our kids or classmates together, or we see them at the baseball fields, that interaction feels more genuine. That trust is developed before that physician walks in the room. I wonder how we can build on those types of relationships with the internist center.
Yeah, I think that those, for better or for worse, those types of relationships are actually easier to build, let's say, in an academic setting, where there tends to be somewhat closer contact. And I will give you an anecdote that established a relationship for me with a radiologist. Actually, was nuclear medicine, but he and I started the same time in academic medicine at what was then Beth Israel Hospital in Boston. And I ordered a VQ scan for ruling out pulmonary embolic disease. And he came up and saw the patient, and that just kind of blew me away to actually get a sense from the patient. He actually did sort of a short history. I don't know what he did as far as physical examination, but that sort of interaction kind of established a bond that stayed for decades as we worked together, because I had that respect that what he was doing was going above and beyond what was absolutely required. So things like that, I think, can often set the stage.
I have a question regarding conveying results to patients for you. I know there's a lot of debate on this topic, but I could just, if I could relay, an example recently that I had myself. I tend to find myself wanting to speak to the patients when there is an abnormal finding that I know I have an expertise in that I also want to minimize. For example, all of us have our expertise. I'm a neuroradiologist. I saw a 35-year-old patient who had a lesion in her frontal lobe, okay? It was possibly a DVA with a cavernoma, but it was atypical. Now, for me to convey this to her, I thought I would probably do a better job, being that it was in a non-eloquent area of the brain. I think some of that could be lost in translation if I pass it on to the primary care, and my ultimate goal was to put the patient at ease, right? I wanted to say, out of all cases, this is the best case scenario you could have. So how do you feel about those type of situations is really my question.
Yeah, thank you. It's a great question, and I'm glad you brought it up, because I sort of realized as I was talking, I didn't want to make this sort of absolute in that way. And a lot of it really, I think, depends on what the patient knows in advance as well. So in other words, if you are bringing up an abnormal finding that is totally unexpected for the patient, I think that's a real problem. If, on the other hand, it turns out that the concern and the patient's concern is much more for something serious, and you, in fact, can allay that concern, I think that that's perfectly reasonable. To me, this is a triad involvement, and in the best of all possible worlds, you want the consultant, i.e. the radiologist, the primary clinician who ordered the study, and the patient all to be involved together. I think that's the best possible scenario. So I think you have to be sensitive to the particular circumstances as far as conveying the information.
I just wanted to comment on that. It's not the best of all possible worlds in a lot of situations. So it's hard to get in touch with primary care practitioners and, and like the last person said, I'm a breast imager, and we understand a lot of breast entities maybe, better than the referring physicians, and we get the patient's blood into the system quicker, and then once we get the trust of the referring physicians, a lot of times they're happy to follow our advice. We wanted a biopsy, we biopsied it, we got, pathology, referred them on, to meet with the surgeon, and those types of things, the internist can still have a discussion with the patient about the diagnosis of breast cancer, but they're not as intimately involved with the imaging. But my question is, I've had physicians call me back like weeks later and say, I got a message to call you.
Yeah, I'll repeat the question since you weren't at the microphone. And so basically your question relates to the fact that it's not always easy to get the clinician. The clinician may find out about this later, and you certainly have the expertise to be able to go over some of the things that the primary clinician might not necessarily be able to go into. Yes, I think that is absolutely right. And again, when possible, what is ideal is if you have that relationship with the expectations with the primary care physician, where it ends up being a little bit easier, I think, to communicate. The primary care physician, in fact, knows what you will, that your standard is to try to communicate more. It ends up being very awkward for the referring clinician who ends up coming in after the fact. The patient comes to see the primary care clinician saying the radiologist has said X, Y, or Z. The primary care physician knows nothing about it. So, a lot of it does relate to both the expectations and the fact that we've got to be communicating better.
If I could just build off on this, this comes into the leadership elements as well. A lot of what the conversation has been so far on this topic, I think for all of us, it's been around since we started our careers. You all hear these things. We've had similar complaints, et cetera, et cetera. And I'm all for what Steve just described in terms of those personal relationships, but if you want to build some consistency of an approach and create the expectation that there should be these communications, then you need to, not just radiologists, but the clinicians as well, and the systems that we all work in, we need to rethink how we do our business at a core level. And this is where a leadership initiative can come in and say, you know what? We've been pissing and moaning about this communication thing between radiologists and providers and patients forever. Why don't we take on some type of leadership initiative in order to try and bring a new type of an approach that engages the radiologists with those expectations, engages the clinicians and the patients appropriately. Recognizing everybody's busy, and so it's not every damn case that we're talking. It's where's the platform, how do we resolve it, what are the guidelines, and set those up so that there's that expectation.
Well, I just want to say one more thing about that. That BI-RADS, which is the language that we use in reporting mammograms, we have the responsibility of making sure that the patients, that those things are taken care of. If we want additional imaging, we want to do biopsies, and actually it takes all the pressure off the referring physician, Because if it doesn't get done, we should have been the ones that have gotten the patient back. And so that you can be more in a watching and looking out that it gets done mode. But if it doesn't, it's our responsibility. And then now there are newer systems, whether it's liver rads and other languages that I assume will be adopting similar policies. And it takes some of the pressure off the internist to follow up on every exam and on every other thing. And I just want to throw that out there.
Thank you. Well, I would also say there may be some differences in terms of a screening study, such as mammography, where the clinician is not necessarily expecting something to be found, and the patient is actually expecting to hear from the radiologist, which is very different from a study where the clinician has referred the patient because of an abnormality that needs to be evaluated. So I'm not sure that they necessarily fall into the same category as far as the communication. You don't like that answer?
No, because I'm talking about both screening and diagnostic. And actually, let's say an internist feels a lump in the breast, but most of those turn out to be nothing. And I'm sure you don't want to be called on every case where it turns out to be nothing. Oh, there's just a ridge of breast tissue there.
Oh, no, but when I was talking about the kinds of things that the radiologist, I think, can appropriately say to the patient, for studies that are normal or where you are, in fact, more reassuring, I think that's much better for the radiologist to do than for those circumstances where the radiologist is finding something that is a surprise for the patient or something more concerning.
And that gets back.
But actually, a lot of those patients where it's more concerning, we jump to biopsy either right then and there or maybe the next day or two. Mm-hmm. And I mean, it could be like 10 minutes later I'm biopsying it.
So again, this reinforces my point. We need to get on to the other questions, but that is at a leadership level in whatever delivery system you're engaged with, help to set these expectations and these channels so that it becomes known and expected at all levels and not a whole bunch of, say there's 50 Steves in your place, you don't need to have 50 different relationships cooking, but each side knows what the expectations are. Sorry to delay.
The other thing I would say, I think it will be interesting to hear Alan's perspective on this.
I'll speak to some of this. Well, speaking of expectations, in the old days when you had x-rays that were in one department and your dictation wouldn't come out for maybe a day or two, you had people come and visiting. And then with the advent of PACS and the advent of voice recognition, we as radiologists think, oh, this is a great job. They can see the films anywhere and they can get that report within 2 minutes. And now we realize, well, not so good because we don't have that interaction we used to. But meanwhile, from the other side, like in one of the hospitals I work at, a smaller hospital, I always tell the hospitals, come down and let's go over the cases. And they don't, because I think they're younger and I think they're used to this fact that they're going to get all that stuff over a computer and that interaction isn't happening. So any suggestions how to encourage it from the other side? And this is not really a leadership so much, it's just day-to-day working.
Yeah, and that's why I had a slide of what the radiologist should do and what the clinician should do, and I think you're absolutely right about that. And for the hospitalist, if you're dealing in a hospital setting, quite frankly, I think that the hospitalist should try once a day to be able to get down to radiology, to try to look at their images and to speak with the radiologist about those images that are of particular interest or concern. I'm not putting blame on the radiologist for this. This is absolutely, I think, as much, if not more, of an issue for the clinicians, because obviously it's more practical and more appropriate for the clinician to come down to the x-ray suite to be able to see the images and go over things with you than for you to go up and try to find the clinician. So I think you're identifying something that we do have to work on.
Becky Haynes, ACR staff for the new Patient and Family-Centered Care Commission, chaired by Jim Rawson. And sir, I would honestly say that leadership is the issue in your situation, where radiologists can take personal leadership of their own situation and get up and go talk to referring clinicians. But I wanted to ask about the suggestion around having leadership initiatives to support communication between referring clinicians and radiologists and patients. And some of that disconnect kind of goes away when you ask patients what they want. And so having leadership initiatives that are led by patients and asking them what they want in terms of communication, and having situations or processes that allow for that variability and what a patient might want might be part of the solution.
No, I totally agree, and I think we'll hear a little bit more about that. And I think part of the leadership is helping to build the structure and then the processes that accommodate many of these sort of sensitive spots that we're raising up. The other unspoken group that often gets lost, especially for the higher acuity cases that go through, are the staff nurses and the respiratory therapists and all those sorts of folks. What are their experiences going through these as well? So it's a very complex thing, and we all kind of know what the issues are, but so how do we set them in so we're developing structures and processes and therefore setting expectations?
So we'll take two more questions to be respectful of Dr. Balch's time, but yes, sir.
So just a couple more comments. We don't have the one-on-one in front of each other interactions, but many PACS systems now have an ability to have both the clinician and the radiologist look at the images and discuss the case simultaneously. So that's one great way you can actually still have those interactions without somebody having to come right down. Secondly, in my experience, I've given patients results many times, either in ultrasound, I'm a GI radiologist, I've done interventions on the spot for patients that have needed. I've never had a clinician give me a problem as long as I let him know the same day or right after. You know, if I couldn't reach him right away, which I usually try to do, I gave it to important results I gave to the patient, but I got in touch with him the same day so that that patient didn't show up a week later in the report and tell, oh, I have breast cancer that was already biopsied and you know nothing about it. That's when the clinician gets mad. They're quite happy if you worked it up and you have something and they know what's going to happen before the patient comes in. So I think that's really the thing is communication. And the other thing is, in the old days, you used to get the paper requisition with a one-word history on it. Nowadays, you should be tying your EMR directly into your wrists and your PACS so you can get any information you want at the touch of your fingers. So your differential diagnosis should already be much more narrow than it was 10 years ago. And you can look up very easily without having to ask the clinician a lot of the questions you want. You can look at their H&P if you're tied directly into this. So I think although there are disadvantages with the electronic systems we have now, in a lot of ways we get a lot more information than we ever had before.
Thank you.
Last question.
Just a comment, perhaps more than anything else. The only people I've seen standing up in this room talking about the way we communicate and wanting to visit rounds and et cetera, are those of us with gray hair. This generation, right? This generation of non-gray hair people in this room, they don't communicate the way we do. I have two sons, and I don't talk to them on the phone. We text. We have to think of other ways of communicating and not interacting the way that we did as we grew up, because this generation coming up behind us doesn't communicate that way. And I think we spend a lot of time trying to reinvent that wheel when in fact it's never going to be the way it was. And particularly with all of us, I mean, I'm at Methodist Hospital in Houston. We got 6 hospitals. You know, we have 5 freestanding EDs. I don't know 3/4 of the clinicians I report to. I don't have any idea who they are. So I think, if we talk about leadership, our leadership needs to start talking about how to communicate in this new world and quit trying to make us go back to the old world.
That's a great point. Actually, from here, your hair doesn't look gray. So. Oh, the back does. But no, I think you're absolutely right about that. And when I talked about kind of establishing that relationship, part of it is the expectations of how people like to receive communication. And I think if we can get to the point where people are using text for communicating these things and the recipient clinician will react to that, that's great. Absolutely. Thank you.
So what a great transition. We sort of changed the order with the patient. We initially planned to have the patient perspective first, but I think now that we've heard sort of the CEO perspective, we've sort of heard the internist perspective. I mean, what a great way to close the session by having sort of an expert on sort of patient expectations, Alan Balch, to come to the microphone and talk about exactly the topics we just described. So Alan, I'm going to bring your talk up if you choose to use your slides. And
thank you very much. And I'll go off the script a little bit and answer some of the questions that came up already. I may be a little bit, I don't want to use the word provocative, is maybe not the right word. I'm going to come at this from an abashedly patient perspective and try not to make it sound like I think that patients have all the answers or that patients need to be trained as physicians, that sort of thing. But just note that that's my bias. In terms of the disclosures, I don't have any financial interest to disclose related to this presentation. I think, is that anything else that's standard that I should get out of the way up front? Very quickly, just to ground you in what we do as an organization, the Patient Advocate Foundation. We're a 20-year-old organization who serves primarily low-income patients. We've been around, like I said, for 20 years, but we were started as a case management organization. I'll talk a little bit about that in just a second. We've served over 800,000 patients over our 20-year history. We're serving about 90 to 100,000 per year. Most of them are cancer patients. How many of you serve or touch cancer patients in your day-to-day lives? That's good. So at least some of what I say will resonate with you in a different way than perhaps if you do not. That's my background, but also I worked with Diabetes Association, the Heart Association in my professional career, and we serve lots of different disease areas as well, over 500 different disease areas actually we served through our case management work last year. So what we do is typically takes one of, there it is. I skipped it already, so there's mine, did that already, no financial. I'd say it takes one of two forms. I reference case management, that's really a very high touch, engaged, sustained effort to help a patient in one of three ways that I'll talk about in a second. We also do direct financial assistance, so copay relief, financial aid funds for transportation, other issues. The three types, our core competencies really competencies in case management are debt crisis, what I would call enrollment assistance, whether that's helping patients with insurance or other SSI, SSDI, low-income subsidy, all the different other things that patients may need to enroll in. And then insurance navigation assistance, so pre-authorization denials, all the different utilization review, I don't want to say barriers necessarily, but hoops that are put in the way of the patient and their provider. And just again to give you a sense of where we come from, probably the most common denominator in the patients that we serve is that they're low income. So most of them have a household income of less than $22,000 a year, and most of them have an average household income of $2,000, which puts most of them right underneath the 200% federal poverty level or lower. Most of them have insurance, so I think there's a common assumption they must be uninsured. Most of our patients have some form of commercial insurance or Medicare. So with that said, I'm going to start with, this is my rock skipping talk, so we're going to touch on a lot of big ideas just at a very small level, and then of course we can dig deeper as we get into the Q&A. I don't need to tell you guys how much perturbation there is in the environment right now. To say that the world is changing in ways that I think make the ACA look pale by comparison, maybe that's a bold statement. But if you look at what's happening with data, with consolidation, with precision medicine, with channel strategies, with quality, with reimbursement, and I put the patient and the provider at the center of all that because I think at the end of the day, it still is, regardless of the communication changes and other things, that transaction is still so personal and unique between the provider and their patient when it comes down to, especially when there's a point of decision, whether it's a decision to get a certain diagnostic or a treatment platform, end-of-life care. So I think at the end of the day, a lot of this boils down to that world, that small world that is that conversation between the patient and their provider or care team. So one thing that is driving this change is the goal that CMS has set to reach 50% payment in an alternative payment model scheme by 2018. So this is a slide from the Learning Action Network. I'm on the guidance committee for the LAN. So we talk all day, lots about, and how many of you know about the LAN and what's happening with the payment models and the goals that CMS, they claim to have met the 30% goal by 2016. So that's driving a lot of these conversations. And I'm going to just introduce a couple natural tensions, and they're a little bit false dichotomies, and I'm not suggesting that one is better than the other. In fact, I'd say in many cases it's some compromise between the two, or one where it makes sense and another where it doesn't. One of those is population versus individual. So I think there's a lot of tension around looking at how do we manage a population and how do you set up systems around population. And that transcends, that manifests itself in conversations around quality, around payment, around clinical pathways, around appropriateness. There's also this need for individualization or personalization. So what is the right care plan for an individual? That's a very personal thing. And like I said at the beginning, that conversation and what to do about the medical issues that face you and all the other personal issues that surround that, that's a very personal thing. So I guess I won't get too deep into this, but just to say, as you're talking about population-based payment, as you're talking about appropriateness of care, as you're trying to find ways to standardize and make care more efficient, which I think is an important goal, especially where we know that standardization reduces the variation that actually leads to higher costs and less outcomes. So if you can reverse that, that's great. But not every scenario lends itself to that. So I think we have a tendency to maybe try to over-standardize, and sometimes not necessarily for what's in the best interest in the patient, but what might be the best interest in the goals of cost containment. And that's important. I'm not saying that that's a very important goal, and we're not patients that we don't put our head in the and ignore the fact that cost is spiraling. In fact, it is for individual patients, and I'll come to that in just a second. So I'd say interrelated to the idea of population versus individual is this tension between standardization and personalization. If you can, standardization in some cases makes a lot of sense. I think this speaks to what we were referencing earlier. I think I don't know that you necessarily have to be, I think we're going to see much more of a process-driven environment where decisions are made somewhat a priori, and that's a good thing. I think where maybe the personalization needed or the opportunity for personalization could actually lead to more efficiency and better outcomes for the patient. I know that sounds a little paradoxical, but I think you can think of in your own workload, where are there places where you don't know exactly what the right answer for the patient is? It's probably going to depend a lot upon their own goals, who they are, what they can afford, what their personal situation is, what their personal life goals are, goal concordant care. So if there are cases where that really in radiology makes a lot of sense to have a more personal individual approach, I think having the radiologist engaged in that shared decision-making process with the patient and their care team, I think will be very essential. If it's pretty standardized, then obviously I think this speaks to what Peter was referencing, build a system where, obviously the touch points can be fewer and far between and less personal where they don't need to be, but where they do need to be personal and individualized, I think radiologists should be part of that conversation. I'll tell you why when I show you some data from our patients. So just keep that in the back of your head. Standardization is a good thing, but not always, especially in a disease areas like cancer where, it's inherently based on genetic variation. So it's as much as we think we can standardize everything, there's something to be said about personalization as well. So what are the tools of personalization? Precision medicine, patient engagement, care planning and shared decision-making, clinical judgment, patient-reported outcomes, social support services through navigation. I'm not going to get into every single one of these, but I'll touch on a few of them as we go. So what are the things, I touch on the last one in particular because, as I mentioned, who we are as an organization, the types of patients we serve, when we open-endedly ask patients, what's your problem? Why have you been referred to us? Why have you contacted us? The number one thing that they actually say, and this is fairly open-ended, is copay for hospitals and providers. It's not pharmaceuticals right off the bat. Pharmaceuticals is up there, but it's actually third on the list. Transportation expenses, copays associated with pharmaceutical products, inability to afford rent, and inability to afford utilities. Now, a lot of that is driven by the nature of the patients that we serve. Obviously, low-income patients are going to have these types of problems. But you'll see, as I show you some other data, what's actually driving some of the need for rent and utilities. Why does that have to, probably many of you know. How many of you feel like you have a pretty good sense of what's happening to patients out there with financial toxicity, what's driving the need for offset with, you're giving up transportation, food, those types of things. So raise your, okay, got it. All right, well, it is definitely, I won't bore you with the methodology, but this is some, just a drive-by on some data that we have from our patients around financial toxicity. 90% report having some degree of financial hardship in the past 12 months. And 83% would characterize that as extremely to somewhat severe. So that just understand that bias of our patient population is they're very financially distressed in very dire straits financially, most of them. These are the types of costs that those patients, when we ask them, well, identify those things that were primarily responsible for your financial hardship. So these are all of those that patients rated at somewhere between 40 to 60%. And it was select all that could apply. And these are in somewhat the right order, but it depends on the population. But prescriptions, office visits, visits to other medical providers, and in that included radiologists, lab services, radiology, and surgery. So radiology is part of the cost picture. You know that, but it is for patients too. So they get those copays, those deductibles, all the different services that we tend to think about. I'm delivering a very important service for the patient. It's worth the cost. It's the other cost in the system that's not worth it, perhaps. All of us have some role to play in the burden that financially that is placed upon patients, which is why I was saying you probably want to be involved in some important ways in those conversations with patients to help them make decisions about what are the financial repercussions potentially, as well as the costs and the benefits and the efficacy and safety of certain radiological routes, for example, or certain tests and diagnostics. So what's happening with this is what's a consequence of that distress? A lot of patients it does have an impact on their medical care, but not at the level that I would have anticipated anyway. The mid to low 20s for most of these things, postponing treatment, not following medical advice. 24% said no impact on their care. Most of what's happening is they're making trade-offs in other areas of their lives. This is the one that kills me every time, is 37% not able to afford groceries. They're not paying their utility bills on time. They're missing their rent or mortgage. They're missing car payments. So thus why patients are calling us for help with those types of things. It's because they're finding a way to get to their medical care and pay for that. The trade-offs they're making is in these other areas of their lives. So I'm going to give you this will answer some of the other questions out there about what is it that patients are expecting, or what makes a value-based experience for patients. This is a survey that we created in partnership with the American Institute for Research and Mayo. It's been validated. I won't go through all the methodology for the creation of the survey. That'll bore you. But it's a validated survey instrument. We've been using it in our own patient population. It's actually live. There's a platform that if you ever want to use it, you're welcome to. It's free. But it's essentially a patient satisfaction survey. So I'll give you some results from our patient population, how they respond to these things. Now keep in mind, this is not about treatment. This is simply about pretty much what happens within the four walls with that clinical patient experience. So the purpose of this was to help identify what are the different values that patients place on their clinical care. Where is there alignment and misalignment between what they value and the care they actually receive? This is what the tool can do. I'm not necessarily going to report all this out to you. And then what are the aspects of care? So there's a whole resource and service section where it identifies and asks patients, well, what resources and services did you need and did you get, and what did you want but not get? So just to give you a little bit of a flavor, this is again from the survey we did. It had about 500 respondents in it, about its 20% response rate, which is pretty good if you consider the nature of the population that we serve. I won't go through these other than to tell you the population here is representative of our general patient population. It's not representative of the nation, obviously, but it is representative of the patients that we generally serve, a low-income population. I forgot to mention we have a fairly racially diverse population as well. And again, most of these patients have insurance, Medicare, Medicaid, or commercial insurance. So I'll throw in a few little, there's quite an array of different topics covered in this survey. I'll touch on a few that I find interesting. And these are all from the survey results from the survey that we did in our own patient population. How far did they have to travel for their cancer care? 23% said an hour or more each way. So that means a quarter of these folks are traveling 2 hours to cancer care. How often do you feel overwhelmed by the time and effort required to get to care? 40% said usually to always. Some other things regarding employment. This speaks to the challenges, the financial challenges of course. And this isn't just cancer. I know from other disease areas, this is not unique to cancer. But at least in this population, 57% before they started their cancer treatment actually were employed full-time or part-time. That goes down to 27.4% after they've started treatment. So imagine the financial repercussions of now you've got this incredible financial turmoil that you've engaged in, and now you've lost your job, or most of these folks are they're retiring or they're going disabled. And then, not surprisingly, then how do you feel worried about your ability to pay for your cancer treatment? 63% usually, it said usually to always, and of that, 43% said always. So the majority of the responses were saying, I'm always concerned about my ability to pay for care, which is why kind of circling back to that conversation before, I think knowing that radiology is part of that, I think there would be a personal interest of your own to get involved in those conversations where you think you can have a meaningful impact in helping a patient decide on what is the right course of treatment for them based upon the benefits and costs and the financial implications to them. Now, not every single time, and I don't know enough about what you do every day and all the different platforms that you could serve to figure that out, but I think it's time and it's worth it to have a conversation about where can you insert yourselves meaningfully, especially in places where I think you can help individualize and personalize that care more in a better way than probably their referring clinician can. So waiting can be the hardest part, and I think there's some good news in here. In the last 12 months, if you had any blood tests, x-rays, or scans, how often did you have to wait longer than you expected? Most patients are saying never, so that's good. There's a few, you got a few down there usually to always, so that I think that's a positive reflection, and maybe a reflection of some of the rapidness and the speed of the electronic platforms provide. I'm not going to go through all these. Happy to share my slides afterwards, but it's interesting to see these are the types of services and resources that patients used. Not what they needed and didn't get. I'll get to that in a second. But this is what they used. The most frequent one is free parking. So whenever somebody asks me, what do patients want and need, what are they using? 2 words, free parking. It gets back to the transportation issue. It sounds petty and small, but to a patient who's living the day-to-day grind of their treatment and all these different journeys that they have to make to the drugstore, to labs, to radiology, to the primary physician, to the specialist, transportation and the costs that are related to that become very significant. So free parking is on the list, of course. Things you probably would expect, helping to pay for care, having a social worker. And again, I want to come back to this idea of if there's not a social support service underpinning all this, and somebody helping the patient navigate through all these different pieces of the puzzle, especially for low-income patients that are financially challenged, I think so much is going to get lost, and it's going to be very difficult for them to adhere to their care. So where are the gaps? What is it that patients are saying, I wanted this, but I didn't have it? 39% are saying they wanted advice about how to reduce stress and anxiety. 38% want, how many of us don't want acupuncture massage services? But that can be very important to cancer patients in particular. Advice on how to control fatigue, free medication samples, information on medical marijuana, advice on how to get or stay physically fit, how to pay for care. And I'm not going to go into this, but just there were some differentials by race and income. There's a whole bunch of pilot tests and field tests. This is some results that we're going to publish here soon on some of the differences between black and whites in the population, particularly around access to services and resources. So some of the big gaps, for example, was actually in free parking, where 19% of the African Americans in the sample in the field test said that they wanted that but couldn't have it, as composed to only 7%. So I just point that out that there are some variations in the access to services and resources based on race and ethnicity. So this, I think, comes to some of the questions that were being posed earlier. What is it that matter to patients? And again, this is purely in that realm of the patient clinical experience. It's not about safety or treatment or any of those other factors that I think are really important that patients should have a role to play in. This is purely about what's the experience like. So most patients, when we say what is the most important to you, these are things, this is the percentage of those patients that ranked this dimension a 10 on a scale of 1 to 10. So 87% said this is the most important thing to them, and they were able to pick multiple ones, so there's a lot. Getting the best cancer care regardless of how severe your cancer was. Getting the best care regardless of your ability to pay for the type of insurance you had. Not having to worry about how you would pay for cancer treatment. All right, so they're right, boom, off the top, the financial pieces. Again, this is our population, so it's going to be skewed towards the financial concerns. Now we start to get into the things that people like you might be able to control. Feeling like your doctors were up to date about your type of cancer and its treatment. Feeling that you understood the next step in your treatment, which again, a lot of the services you provide will help determine what that next step is, which is why I think for patients, I think if there's choices or there's significant implications of the results of their screening, I think there is an opportunity for patients to hear directly from you about those results. having your doctors take what you say about your treatment seriously, having the cancer care the team work together as a team. So I think that's another, how many of you work in a team environment? I would consider you very much a part of the team. That's really important to patients. Having your care team talk with you about how to manage side effects, make you physically comfortable, treating you with respect regardless of your age, the gray hairs out there, you don't want to treat people disrespectful, on either end of the spectrum because they're either too young or they're too old to know better or know anything about their care. Being involved in decisions about your cancer treatment as much as you want it to be, and having your cancer care team explain things in a way that is easy for you to understand. So I think if you're going to engage with patients, it's very critical that you be able to talk to them in a way that they can relate to the information that's coming out of your mouth. And so we use, doctors like to use words like response time, or we see a response from this treatment, or from, patients often interpret the word response to mean cure. So you have to be really careful about the terminology you use if you're going to be interacting with patients and making sure that it's a language that they can understand. And so if you want to use the value index, that's called the Cancer Care Consumer-Based Cancer Care Value Index, send an email to here. We'll set you up on an account. It's free. It works like SurveyMonkey, or if any of you have used COA's Medical Oncology Home Survey, it's actually the same platform. You get a free account. You can put your own logo on the survey. You get your own results. They're de-identified and aggregated to you, to your account. So you can access them almost in real time as patients you get a link that allows you to send out your survey to your patients and get the results back. I'm going to end on this note because I think, again, from a big picture perspective, it addresses some of the conversations that we had already. This is our official Patient Advocacy Foundation, has an official a set of policies and principles around the care team's role. We feel that providers have to have the freedom to consider a range of viable treatment options and with the patient carefully weigh the risks, benefits, and costs associated with them. Again, not every single time, but where it's appropriate. We want to guard against policies that might short-circuit the shared decision-making process by substituting clinical judgment with automatic predetermined options. Again, not every single time. I think there are times when having a predetermined option makes sense. There are other times when it really needs to be individualized and personalized to the patient. And I think we're sort of maybe knee-jerking a little bit far to the other extreme. We want personalized medicine, not cookbook medicine, but an appropriate steps should be taken to encourage and empower providers to engage their patients in robust shared decision-making processes at multiple points in their care experience. So I'm going to stop there. I think we've left about 10 minutes for even more questions and answers, but I apologize if I went a little long.
No, you did great. The timing is perfect. So we have about 8 minutes till the top of the hour. So I'd love to hear some questions building on some of the themes. I'll start with one. And when I read all three of the columns these gentlemen wrote, every one of them talks about clinical decision support. And we think about that as a tool for our referring physicians, but if you talk to them, they oftentimes will use that as a tool to guide their discussions with their patients. So I'd be curious what both faculty have to advise about sort of the best ways to implement those types of programs into our practices.
Yeah, I think the first thing to do is create something that can be standardized. As much as I wasn't railing against it, but you might have left there thinking, he doesn't like standardization. Actually, I like the idea of what you might call a scalable customization or custom configuration. So if you can standardize a process like shared decision making and figure out at what point should radiologists be directly involved in those shared decision making conversations, either at the point of deciding whether or not there is a treatment or a diagnostic or an image that should be ordered, and then, of course, what's the interpretation, how to read that, and the implications of it for treatment options. Those are two transactions where I can see radiologists being involved where it makes sense. But it's not going to happen in an efficient way if you don't sit down and kind of chart out, like an algorithm, where does it make sense, and where are those decoupling points, if you will, where your expertise is really going to help shape and individualize a plan to the patient's individual needs and preferences. And that if we overstandardize the whole patient journey, that's going to become more and more lost, and the journey will just seem like it's all about numbers and pushing patients through. And I think if we go to that may be a very effective cost containment approach, but it's going to lose the humanity of healthcare and what that individualness, that individuality of my diagnosis, and what is the impact this is going to have on my life. So I think it really lends itself to the need to think about how to create a system so that can be replicated and scaled, and so the expectations are clear for for the referring physician, for the care team, for the radiologist, but I think it really should be done in a way where you find out from patients. Becky sort of alluded to this. What is it that patients want and need? What are their questions about radiology? What's their normal experience with that? Speaking personally, I'd rather talk directly to the radiologist. I have a lot of doctors and nurses and PAs in my family. When I get those results, I want to hear directly from the radiologist. That's just my own bias, and I don't think you should make that open every single time just because a patient wants to talk to the radiologist. It may not make sense. But I think it should be some balance between standardizing the process, but figuring out where can you play a role in helping to really customize and individualize figure out how do you make that radiology plan, if you will, goal concordant with the needs and preferences of the patient. Sorry.
I'm really glad you brought up the point about cost, and one of the things that we have been concerned about is the value of the different things that we provide to patients, and the fact that costs are not transparent at all, which is incredibly difficult. And I show a slide, and I would just be curious here. I show a slide of actually a relative of mine who had an MR of the pelvis. And I would just ask, how many of you have a sense at your facility, how many of you feel you know what the cost of an MR of the pelvis would be? Okay. Someone want to tell me what you think approximately a cost would be for an MR of the pelvis?
Component, are you talking about a freestanding imaging center or the hospital?
I'm talking, this was a hospital.
Component for pelvis of a hospital, probably going to run somewhere between 6,000 and 8,000.
You're pretty good.
This was, you get a sticker?
No, when I've said that before, a lot of people said between 1,000 and 3,000. Actually, the cost, it was $9,738.
Oh, okay. You're probably on the East Coast.
I gave a talk in South Dakota, and when I mentioned that price, a woman in the audience said, I just had that study done here in South Dakota, and it was $8,000.
One of the things that was interesting in noticing your slide, that 80% of the people you're dealing with have an income level under $35,000.
Correct. And in the survey results too.
Right, just from what you showed up there. There's a lot of 4 and 5 member families with $50,000 or $60,000 in income that we make, and I know I'm interested to hear what a lot of people say. The first couple of months of the year, when all of a sudden the insurance rolls over and the copays are back up, we had tremendous drops off in hospital admissions, everything else. And what do we see here is, I see this as a crisis because ultimately, yes, we're not getting paid, but that's not the point. So a lot of people aren't getting the health care that they need to get. And how long will that last? How many months through the year will they put off? And you even had a percentage here that people have life-saving care that's there that they're putting off potentially. I see this as a major crisis for patients themselves in that they can't afford the copays, and they're putting them off and rationing. Okay, well, now I got to feed my kids rather than pay for my own heart medicines. So, radiology care, whatever it is, and what the approach our college and everything else is going to have toward helping these people.
Yeah, I would probably preface my comments by saying I'm assuming the status quo in terms of the United States sticking with the current system we have, which is a mix of a hodgepodge of sort of publicly supported medicine as well as private, all the different actors, that we're not going to move towards a single payer system or a national health system. Now that may change, but I don't know that, and I'm not going to take a side one way or the other. If you've had a few drinks, you'd probably quickly figure out where I fall on that scale. But so I will preface this by saying that I would assume that's the future. And so assuming that is the future, I think we are at that point. And that's why I think it is a crisis. But crisis creates opportunity, which is why there's so much change right now. And I think you can either let it overwhelm you, or you can use that as an opportunity to engineer and change the system in such a way that actually makes it better. And I think that there's so much focus on the cost side, and rightly so, that the solutions that we're going to drive to are more about the cost containment piece, which is an important one. But I think if we move too far unless we just go right off into the national, into an NHS-style system, which you can make an argument for, but if we're going to try to keep the current system but engineer a bunch of rationing and cost containment in it, it's like, what's the point? So if we, you kind of lose the innovation and the individual, the ability to individualize treatment if you overstandardize in the name of cost containment, which in the certain socio-political economic context makes sense, but not in the one we have right now. So in the system we have now, I think we need a concerted effort to think about how do you cost contain, but actually and where do you standardize in a way to make things more efficient and more cost effective. And there's a lot of cases where if you trusted the patient and had a really thoughtful shared decision, how many of you feel like patients might make, the patients that you're dealing with, or that when you see the test, they might make a actually cheaper decision about what test to get and what to do with that test than if it was sort of laid, someone said, here's the standard of care, here's what you should do next. How many of you feel like patients would generally, might actually pick a cheaper option if you left it up to them? Not every time, sometimes, right? So I think there's this tendency to feel like we can control these things. We can set up this massive system to control costs by over-standardizing. And that, from a patient perspective, I hate to use the word, but it feels like coercion, which in some cases may be okay, where we really don't need to give you a choice because the evidence is pretty darn strong that you don't need 10 different options here. There really should just be the one option or the one or two options. But I think there's a lot of it where that cooperative approach and really having that conversation with the patient, and not that they should become experts in diagnostics or radiology, but what they can be experts in is what are your goals in life? What are the risks and benefits that you're concerned about? Patients can easily come to a shared decision-making conversation with those kind of things in their heads. They are experts about that. Your job should be then to line up, here's what I know about you, and your personal values and preferences and what your goals are against different treatment options. So I understand those better than you do, obviously, because I'm trained to do these things. You know what you're trying to get out of life and with your treatment. Let's see if we can pair those things up together in a more effective way. Then they're invested in their treatment plan, right? Then they understand why you're collecting these data from me, why I need to do X, Y, and Z. It's a different feeling when it's that era of collaboration and shared decision, that aura of collaboration and shared decision making.
Perfect. So we're at the top of the hour. I'd love to hear what Dr. Rao has to know. It's fine, you're perfect. So I'd love to hear what Dr. Rao has to say, and then we'll close the session with your comment or question.
Okay.
We'll stick around up front for other questions.
Okay,
So you're fine.
A quick comment. So, this cost discussion is very, very interesting. And I think we do a lot of disservice to our patients. It's the so-called charge masters that hospitals have with absolutely outrageous prices, but those are not real prices. Because when you look at an imaging center, the global fee that oftentimes imaging centers get for an MRI of the pelvis is like $400, or $420, something to that extent. But when the patients see their bills from hospitals, or when they call the hospital, what will this MR cost me? The hospitals will tell them what's on the charge master, which is like $6,000. So it's really, really such a big disservice we do to our patients by giving out that kind of information. I think hospitals really need to pay attention to this, what we are doing.
Well, what the patient needs, and very occasionally I've seen this, is where you can customize based on your insurance and the particular facility that you're at, what will be your obligation as a patient. That's very hard to find though.
Right. And just one other very quick comment is for cancer patients, I think where radiologists really function as part of the care team in making decisions what's appropriate imaging or not appropriate is in the setting of tumor conferences. So most institutions have, so-called tumor boards or tumor conferences, because that's where we kind of make our contributions. We don't have that opportunity to deal directly with the patient.
Yeah, and that's a good example of a case where that may be a better way to systematize that. So I don't have all the answers, but I think thinking through and a lot of smart people getting together and saying, where are there places where radiologists could be part of the care team in different ways? Where should they be interacting and intervening more routinely with patients in certain circumstances? So.
Yeah. And so I want to thank my co-faculty. I want to thank the audience. This was a discussion which I thought was lively, sort of went directions I'm not sure I could predict, and I hope we all got something out of it. So enjoy the rest of your week, and thank you again.
Happy to stick around. And if you had a question, others that had questions that didn't get a chance to pose them.